invite again Dr. Ragini. She is going to speak to us on the intumescent and hypermature cataract. Ragini.
Thank you so much, sir. खाली जाते. Excuse me.
Here कर. Escape करो.
So hypermature cataracts are definitely difficult to manage. Okay, thank you. Thank you so much. So what are the challenges when you are faced, that you face in a hypermature cataract? They are multi-pronged. So there is no fundal glow. The rexes, when you do, because the cataract is so intumescent, can get extended. There are more chances of nucleus drops if it can be a complicated surgery. The IOL can get decentered. There will be endothelial damage because of your manipulations, and there are chances of posterior segment rupture. So how can they be tackled? The use of trypan blue can be used to manage the no fundal glow. Use of rexes forceps can be done to make a good rexes. We need to have an anterior vitrectomy and standby lenses available in case of an untoward complication. VR surgeon referral is extremely important for a nucleus drop, and you have to use a good viscoelastic to protect the endothelium. Whenever there is any decentration of the IOL, so if there is a proper bag, the chances of decentration is very, very less. But if it is there, then intervention will be necessary. So we will see a few cases of hypermature intumescent cataract. As you can see over here, this patient not only has a mature cataract which is intumescent, but there is a calcification in the anterior capsule, means whether there was any trauma. The capsule is always stained with trypan blue, which makes our life much easier because there is no glow, otherwise it would be very difficult to do a capsulotomy. It should be away from this area of calcification. And as you can see, if you have difficulty in doing the rexes, if you see the initial part of this video, I'll just show again that we are using a needle here to do the rexes in this video, and you see that there are chances of this rexes going out. So now we have changed to this forceps. So it's okay to use a combination of these two to do a good rexes, because if you feel that you have better control with the forceps, then to come out, put viscoelastic again and use a forceps. Micro forceps from Epsilon are also available, which can be used to do a good rexes without too much of manipulation through a small entry. As you can see over here, there is no epinuclear buttress. The nucleus is vertical, and now there is no hold over the nucleus. So that is very important, that there is no epinuclear buttress. You have to have a machine which has a good followability. Followability means the ability of this phaco to hold itself to the nucleus, and then it can be divided. If that is not there, the nucleus will keep on roaming, floating around without being chopped. So you should have enough power to hold this nucleus to the phaco tip. Once it is held, then with the chopper, it can be chopped into multiple pieces and it can be emulsified. So as you can see over here, you may not end up with a proper finesse with techniques and all that, because the nucleus is floating around. So you have to use the chopper, which is a very, very essential tool to help you feed these pieces or to hold the pieces or to control the pieces while doing the phacoemulsification. Now just wait. If you saw the last part of this case, one has to wait before coming out, otherwise there will be a surge. This is the second patient. The tunnel is very, very important. A complete and the correct size tunnel is important. Otherwise, the fluid leaks and then there will be problems. As you can see, this is definitely a hypermature intumescent cataract. We are doing our rexes. Some amount of milk will escape the cortical milky material, and one has to tackle it. Doing the rexes, having a lot of patience during the rexes in these cases is extremely important, because the nucleus is very intumescent and the capsule consistency may be different. Here also again we have used two instruments to complete the rexes. First the needle and now the forceps. it's okay to do it because what is important is our rexes. Now all the milky fluid is aspirated and you see a large nuclear cataract inside. Once the cortical milk is removed, you embed the nucleus with the Phaco chopper and you do a straight Nagahara's chop in this patient. If you cannot do it, then you trench it. So what is important is that you try this, for this Nagahara's chop, using a high ultrasound and embedding the nucleus and using the chopper effectively to make that chop is extremely important. The nucleus keeps on rotating because there is no epinuclear support and nothing. One has to see that when you chop, the posterior fibers which are interdigitating are also chopped. The nucleus is very large, so multiple small pieces are made before you emulsify it, and gradually till the posterior layer of the interdigitating fibers, because if the nuclear pieces are not completely chopped, they will get entangled and the sharp pieces may tear the posterior capsule. So a complete chop is necessary. Once you have, then you can start debulking by emulsifying one piece, and then one piece at a time the nuclear pieces are emulsified. Here you can see that the nucleus is bulky, so that more than 4 pieces are made, because even the 4 pieces will be very, very large. So multiple small pieces emulsification is important. And at the end of emulsification, to wait before withdrawing so that there is no surge. These are the important points to remember. One more intumescent cataract. The availability of good quality Indian intraocular lenses, good Phaco machines of the Indian make it possible to do Phaco emulsification even in this. So this milk needs to be tackled before you aspirate it like directly by using this syringe on which the capsulotome is mounted, and then use a Utrata's forceps or microforceps to complete the rexes is very, very important. Blue rex is definitely a boon for us in these hypermature patients, and once the rexes is complete, it is good to do a Phaco emulsification, because otherwise with no epinuclear buttress and the anterior capsulotomy extending, it would be very, very dangerous for us. Now to chop this nucleus, you have to use a modified central horizontal chop. Horizontal, vertical, what you call it, what is important is your machine. So whenever you buy a machine, whenever you are understanding the fluidics and the dynamics of the machine, the followability of the machine, the complete proper use of ultrasonic power in that machine, and the chamber stability, these are the factors which will make a big difference to the success of this case. The chamber stability is very, very important, because otherwise if there is surge, then you cannot manage this patient. There is no epinucleus, there is no cortex. What is there is only this hypermature cataract. But Phaco emulsification is possible in these patients. So this is a hypermature cataract, and what we will be showing here is what is not to be done. So you go in and try to do the rexes in this patient, and you can see it's difficult to do the rexes because probably there is a soft cataract inside and you are trying to do a rexes, and while doing that, so much of the cortex and the liquid cortex is mobile in this patient. So this itself gives you an indication of the danger or the problems that are going to occur. There is crumpling of the capsule, as you can see over here, which is making the capsulotomy and the capsulorhexis very, very difficult. And you can't do it because it's crumpled. And it's hypotonic because there is some amount of trauma or subluxation in this patient, which you can make out only when you are doing the rexes, because it would be very subtle or it would be in the periphery. So you use the forceps to do and complete the rexes and to manage it, and you can see that there was a traumatic cataract, which that fibrotic element which is visible here, which may not have been visible when you are starting the case. So the hypotenuse capsule gives you an indication of the problems that are present. So this is another video of a hypermature cataract. Again, the tunnel, the correct sizing of the tunnel, the blue rex stained capsule and the capsulotomy, these are very, very important preludes to a proper Phaco emulsification, which cannot be taken lightly. Now, as you can see, this is intumescent and your cataract, the rexis is already extending and it is progressing towards an Argentinian flag sign. And now you have to modify this in such a way that
Ragini,
you
1
have.
minute. Now see, this Argentinian flag sign has happened. Slow karo usko. It is just because, see, slow karo usko. See what happens, whenever you go and tear the entry capsule, if you tear in the straight line, in such cases, straight line, then that is going to be Argentinian flap. First, you can aspirate the fluid, reduce the pressure, one. Or you can do a small rexis in the center, and then you can do the large rexis. Or if you are doing, then the curvilinear. It means curvilinear tear in the anterior capsule. So unless and until you do that, it is going to be Argentinian flap sign. That is just because we are having the habit like this or like this. So that habit should not be there when there is a fluid in the lens. So remove the fluid by the lens. Before that, they are removed by the 26 gauge number needle. They are removed fluid. It was subluxated. The zonules are weak. So that will help you. The rexis was done there. So in such cases also you aspirate the fluid, reduce the pressure inside the behind the capsule, or otherwise make a small rexis in the center, or curvilinear incision. Curvilinear. It should not be linear incision at all. Go ahead.
Yes, sir. So very true. So one has to be careful, otherwise you land into this complication. So one has to be very careful and very conscious while doing.
Now see, wait, see the flap. You can see the flap there. Wait, Ragini.
Yes, sir. Yes.
So that flap is moving. Now this is a Rohit Om Prakash who told about this sign. If the flap is moving, it means there is no PC tear. If flap is not moving, there is a PC tear. So that flap movement sign is very important when you want to do phaco emulsification. Otherwise, you should not go ahead at all, because that is a PC tear. Now here there is no PC tear. Only thing is that there is this Argentinian flap sign, extension is done, but no PC tear. So if you do consciously, cautiously phaco in this, you will succeed. Go ahead.
Yes. So very important tip, sir, and it is also important. So this is what sir was saying, that this Rohit sir has given this important tip to us, and one must give credit to the person who helped us. So these, more than the good videos, these are the videos which help save ourselves when we know and learn from the mistakes of others, and trying to do a safe phaco here, because we know that likely that the posterior capsule has not been damaged, the tear has not extended. And then to complete this, so basically the take home message is to use the die for the capsular tane, use a sharp chopper, stop and chop technique or nagaharas, whatever works, effective use of ultrasound energy, which is very important, and to choose what is effective in your hands. I would also say that the technique is also important. If phaco is not possible, then SICS also works. One must not feel inferior, but the patient always comes first. Thank you, sir. Thank you so much.
Thank you, Ragini. So if someone want to ask any questions, we have hypermature is finished. Hypermature is already covered in the intumescent. So I think all type of cataract, it may be a soft cataract, then the hard cataract, hypermature cataract, nuclear cataract. Every cataract can be tackled with phaco emulsification, and the team has shown you the different techniques which can be used, different types of machine. You can use any type of machine. It is not required that it should be only higher end machine. Any machine you can use, only you must know that machine properly. And once you know the machine properly, then you can do phaco properly. So for that you will have to study machine also and see your videos. Once you see your videos, whatever you have done the mistakes in the past, you will not do in the future. So thank you very much. Thank you, Dr. Gopal. Thank you, Navneet. Thank you, Siris. Thank you, Ragini, for this, and everybody for attending in such a large number. Thank you very much. You will have one photograph. Is there photographer?